Welcome to another episode of Progress, Potential, and Possibilities, discussions with fascinating people designing a better tomorrow for all of us. I'm your host, Ira Pastor.
Welcome, everybody, again to another episode of our show. Today, bringing you another really awesome guest involved in creating a better tomorrow. We're going to be talking about some really interesting technologies today that we have not, gotten into much on the show. Specifically, this area of extracorporeal membrane oxygenation, really interesting form of life support for patients whose hearts and lungs are unable to supply function. And literally, our guest today is the gentleman that wrote the book on the matter. We have the honor of being joined today by Dr. Jeffrey DellaVolpe. He's medical director of the Adult Extracorporeal Membrane Oxygenation Program, or ECMO program, at Methodist Hospital, San Antonio, Texas. He's also the medical director of the Cardiovascular Intensive Care Unit at Methodist Healthcare System and the Texas IPS Critical Care Service Line. He also serves as the chair of the Joint Society of Critical Care Medicine and Extracorporeal Life Support Organization Task Force, and has created a really unique platform as well for both ECMO training and transport. Dr. DellaVolpe served as a flight surgeon in the past with the 27th Special Operations Wing. They are deployed twice in support of Operation Enduring Freedom, Trans-Sahara. After completing his fellowship, he was assigned to the San Antonio Military Medical Center. There he served as a critical care physician and member of the 59th Medical Wing Critical Care Air Transport Team and Acute Lung Rescue Team. He's originally from Newport, Rhode Island, received his bachelor's degree from Dartmouth, then went on to attend medical school at Tulane University School of Medicine, and then completed his residency in internal medicine at the Tulane Medical Center and fellowship in critical care medicine at the University of Pittsburgh. His book, the ECMO book, published by Elsevier back in 2023, is available at all major booksellers. Honored to have him with us. A lot of really interesting topics we don't normally get into. Dr. Jeffrey DellaVolpe, thanks so much for taking the time to come on the show, and of course, thank you for your long service to the United States.
Thank you, and thanks for the invitation. Excited to be here.
I'm really excited about, all the topics we're going to be getting into today. Would love to, as we typically do, hand things over to you to get started so we can learn a little bit more about you. Would just, love to go back, hear about, sort of what got you interested in medicine to begin with, what got you interested in critical care medicine, and a little bit of the early days of your journey before we start talking about ECMO. Please take the floor, Jeff.
Yeah, absolutely. No, it's been a pretty interesting journey for me. I think what got me interested in medicine has been just the opportunity to really follow in the footsteps of some fantastic physicians and seeing how they've been able to really just change the care for patients. I remember early in medical school, I had the opportunity of just really being instilled with this value of putting the patient first and being able to help that patient, that sacred relationship that exists between the patient and physician. And for me, that really kind of manifested itself in being able to take care of the sickest patient in the hospital. That's really what drew me to critical care medicine and ultimately towards some of the more advanced forms of support, such as ECMO and such as extracorporeal life support, all the things that I'm sure we'll talk about.
Absolutely, most definitely. And yeah, I mean, before we get to ECMO, I'd love to talk about a couple of topics that we maybe have briefly raised on the show, but would sort of like to reintroduce our audience to these. The first of them being this principle that you wrote about, back in this was 2010 in the Journal of Trauma. Known as damage control resuscitation. And this, we briefly, in talking to some of the folks a couple of years ago from DARPA, we're introduced to this principle of the golden hour that, we have a lot of preventable death. Hemorrhage is this major issue, of course. We're a species that dies pretty rapidly when we bleed, from loss of blood, of course, loss of oxygen. We have a period of time, whether that's blood or other interesting hemostasis tools to restore life, to keep someone alive. Talk about the principle, if you would, of damage control resuscitation, and a little bit of what that encompasses broadly as a sort of its own domain.
Yeah, I think it's a very interesting concept. Damage control resuscitation really encompassing the ability to do quick repairs that are needed to be life-saving, to be able to go then quickly to the ICU, to be able to continue the resuscitation, and then do multiple takebacks so that way you can just be able to prolong that resuscitation and get people stabilized quickly. It's interesting because I think as we've really kind of progressed in how we've thought about critical care, it's a lot of that has come full circle as we really think about how do we bring the highest level of critical care to the battlefield, to the tip of the spear. It's been a concept that I've really had to revisit over the last 10, 15 years, and certainly wouldn't say I'm the expert in terms of trauma resuscitation. But it's certainly something that I continue to think about in terms of how we develop out a lot of this support technology.
And you mentioned the battlefield, and that's another area that we've touched on in terms of this concept of the austere environment. Now, most of us, I was listening to this show, watching it, won't find ourselves, in Afghanistan or an extremely inhospitable realm. And most of us probably, hopefully, won't have a major sort of penetrating chest wound where both the heart and the lungs are compromised. But as and we'll get into this in a little bit. Clearly, the last couple of years, especially in the context of the pandemic, have shown that when the lungs don't work, things go wrong. And would love to, if you could also just touch on the principle of the austere environment, not just from obviously the inhospitable area that one may find themselves in, but the inhospitable conditions, whether that's a wound or, in the case of lungs that don't work, acute respiratory distress syndrome, which we heard a lot about the last couple of years. We need to think a little differently about how we treat these patients.
No, I think your analogy is correct, and it's actually very relevant. I think a lot of us are tired of talking about COVID, but if anything, I think it was just a very relevant case study of what happens when you have a debilitating disease, debilitating condition that is really, in some cases, can only be managed by very resource intensive and resource limited technologies and support. So yeah, austerity isn't unique to the battlefield. It's we sit in South Texas. We sit in a catchment area of about 10 million people, many of whom don't have access to things like ECMO, things like advanced critical care, things like some of this other types of support that we're talking about. So it's very relevant, and how you can identify patients who could decompensate, how you can be able to mark them, identify their biomarkers, and then transport them to the right level of support. Again, I think this is the exact same story that has been playing out with battlefield medicine for a long time.
Okay, perfect. And that segues nicely into where we're going to go next. And the principle of extracorporeal therapy in general, the concept of withdrawing blood, doing something, and ultimately returning it to a patient. Clearly, people listening and watching this show no doubt would have some, exposure to the concept of dialysis, kidney dialysis, potentially the application of these tools for removing certain poisons. We talked a little bit about plasmapheresis on the show. In terms of ECMO, though, we're going on steroids here. We're going a lot further to major support of both the heart and the lungs. And interestingly, reading about it, I mean, this technology goes back quite a few decades, obviously not on a major scale. Talk a little about the history here with regard to ECMO, in sort of when it was originally thought up, what it was originally used for in terms of sort of, I guess, the neonatal world, and then how it's sort of expanded since then on the scene.
Yeah, the history of ECMO is fairly interesting because, like you say, even though it tends to be seen as a cutting edge technology, it's a fairly old technology. It really dates back to the 70s for the first ICU application, where you actually saw that it could work. In that case, for a trauma patient, for that first use that was being done, and the patient that was able to survive. What If you actually look at the history, it had the advantage of being studied very early in a rigorous standpoint. There was an NIH-funded, randomized, controlled, multi-center trial that was put out there, and that studied it very early on. The problem is that the technology and the use of the technology really hadn't caught up to the rigor of study. And what you saw in that early trial was just a very high mortality in both sides, in both the control patients as well as in the ECMO patients. So that really put a very bad taste in people's mouth, I think, for adult use of ECMO. And like you said, it really kind of moved more into the realm of neonates and pediatrics for quite some time. But as you look over the next couple of decades, what happened is the use kept going on. People kept adopting it more. The technology got better. The cannulas, the oxygenators, the pumps had gotten better. And what we also saw was just more and more uses where you could see that it would be of use and helpful for patients, particularly around viral pandemics. There was the swine flu pandemic, there was various influenza pandemic, the SARS pandemic, and then finally going all the way up to COVID-19, where we had these very small, select, but distinct cohort of very sick, previously healthy patients, and just an inability to oxygenate them, an inability to support them, and the ability to use a tool like ECMO that could be able to help. So what we've seen over the last several years is the advent of many more clinical trials being able to define out the use of ECMO, much higher increasing utilization around different indications, and importantly, the much more broad adoption, both in terms of providers, but also in terms of awareness from the public. And I think that's really going to inform the journey for ECMO as we look towards what does the next 5-10 years look like.
Could you introduce us a little bit to sort of the basics of what goes on in the process? Obviously, you're taking out blood, you're oxygenating it, but obviously blood does more than just allow us to live. In terms of oxygenation, you have to think of a lot of other things in terms of the various gases that blood carries, bleeding management, coagulation, and then oxygen important, keeps us alive, but too much oxygen and we run into reperfusion issues. Walk us through a little bit of just the overall process and a little bit of the types of things, because clearly, as you were mentioning, it's been around. We have a lot more to do with it. That's great because, there's going to be many new iterations, undoubtedly, of this technology. Take us through a little bit of that. Introduce us to these various dynamics of the technology that you have to think about.
Yeah, I think the fundamental mechanism of ECMO is almost deceptively simple. It's like you say, it's pumping blood outside of the body, either through usually a centrifugal pump or some roller pump or some other mechanism. It's being able to pass it through some oxygenator that basically utilizes the diffusion gradients of oxygen and carbon dioxide within the gaseous phase and within the blood phase to be able to oxygenate the blood and to remove carbon dioxide. And then it's being able to pump that blood back into the body. There's really two different flavors of ECMO. There's a respiratory ECMO or a VV ECMO, where that blood gets returned back into the venous system. So fundamentally used to support, primarily used to support respiratory failure. Or there's VA or cardiac ECMO, where that blood gets drained out of the venous system, returned to the arterial system. So you have either partial, near complete, or complete cardiopulmonary bypass that becomes affected by that, depending on how high that's being written. And then in that case, being used for a variety of indications, to include cardiogenic shock, to include heart failure, pulmonary embolism, cardiac arrest, et cetera.
Mm-hmm. Mm-hmm. And I think, again, we talk about acute respiratory distress syndrome being a major topic, during the COVID era. But I believe, a couple of years before COVID came on the scene, you published an interesting paper of ECMO in acute respiratory distress syndrome, specifically in burns. And, what I'd love to hear, a little bit of your experience at that time. And then obviously as COVID happened and we had all this other stuff happening in the ICU with regard to ventilators. What were you involved in at that time in terms of, hey, clearly these ventilators are useful, but there's a lot of problems. We got this ECMO thing here. Explain what was going on sort of pre-COVID with your experience with ours, and then what happened as you transitioned into COVID with trying to get the technology out there to more systems.
Sure. Just to kind of synthesize both sides of that question, because two very different ends of that coin. I think pre-COVID, if I were to really summarize kind of how I've been approaching ECMO, it was really trying to delineate out which are the patients that could be maximally helped from this type of support. And again, that's just one of the fundamental principles that I think is just so important. It's why I really am so drawn towards this support and towards this technology, is that it forces me to think, how can this mechanism and how can this mechanistically help my patients? Or what I'm doing before I go on ECMO, how is that mechanistically hurting my patient? And being able to run that calculus around that. I think that's the fundamental question around ECMO, and really in many cases, the fundamental question that still needs to be answered. So like you referenced, I think a lot of times that involved being able to say, okay, what were the patients that could be helped, even if it was not your traditional patients that were going on ECMO, not necessarily your viral influenza, your bacterial pneumonia, but for example, your patients who had burn, trauma patients, patients with manifestations of malignancy, things that are traditionally said, okay, don't even go there with ECMO. I think where I was very interested for several years and continue to be is, instead of saying, okay, this class of patients could not benefit from this, what subclasses of these patients could actually benefit, especially if we are harming them with things like the mechanical ventilator or the various vasopressors they're on, or the sedation and deep paralysis that they might be being subjected to as a result of their disease. Kind of segue that to COVID, I think then things change quite a bit. Now, instead of being able to have a very, homogeneous view towards a heterogeneous population, now you have a very discrete, a very large population, but everyone being impacted by the same cause, where you have one virus that is really causing an overwhelming number of patients with severe hypoxic respiratory failure. And then being able to not only try to understand how we should best use this technology and how we should best triage the small number of resources that we had, but also how do we apply it to various populations, to patients who are obese, to patients who had been subjected for a long time to the mechanical ventilator, who had been subjected to a short time to the mechanical ventilator, maybe those who had not even yet been subjected to the mechanical ventilator. These were the things that we really had to do to be able to respond in hopefully a thoughtful way, in a way that put patients first, for how we were able to apply this technology.
And if I mentioned, in the bio of the show, aside from all the work you're involved in with regard to ECMO and of course, the developing and the continued developing of the technology, like writing a major book about it. You've also been actively involved in creating, training methods, transport methods. There's an interesting, organization you're involved in called ECMO Transport, and I'd love to hear a little bit about that as well. But, in looking at the availability by country data, there's a certain amount of hospitals and then units that are out there. There's more than I thought would be involved, but clearly for the thousands of hospitals in the United States and those around the world, it's still a small percent. Talk a little bit about sort of the acceptance, the uptake of the technology as you've seen over time, and then the importance of transport and understanding that, I guess, the unique dynamics of transporting patients under this technology that you're learning about with a group like ECMO Transport.
I'd be remiss to say that when we're talking about ECMO, we're really talking about resource limitation, that this is what, in a fundamental way, what we're dealing with, that we're talking about, it's always going to be resource limited, or at least in terms of how we're doing this now. If it's not because of the availability of machines or circuits like we saw during the pandemic, it certainly is a function of a shortage in terms of the expertise to be able to manage these pumps. And that's a big thing that we continue to deal with, even post-pandemic. It's always, do we have the nursing support? Do we have the ECMO specialist support? Do we have the physician support to be able to maintain capacity? I bring that up because I think that's very relevant to those two platforms that you speak of. The first one being training. I think being able to train people to do this well, do it safely, is something that I'm passionate about. I'm very aware that patients who happen to walk into the emergency room at my hospital may have access to a different level of support than the patients who walk into an emergency room of a hospital that does not have ECMO, that does not have access to ECMO. So in order to be able to level that playing field, to be able to make sure that patients really have that access to care, I think we need to be able to expand the care. It needs to be able to be done well by a broader group of people. And in cases where that can't be done, I think transport really exists as a way to be able to bridge that gap. That if I have patients way down in the valley in South Texas that are in respiratory failure, if they're too compromised to be able to be transported to me without ECMO, well, then it's contingent for us to be able to bring that ECMO support to them and be able to transport that patient on ECMO and be able to get them to that definitive care safely.
Jeff, you published a paper a couple months ago. It was titled the Extracorporeal Life Support Organization Registry, International Report 2022, an overview of 100,000 survivors, which, sort of complex, review of the last couple decades of patients. Can you talk about the ELSO, the Extracorporeal Life Support Organization, the database that it maintains, and just a little bit of what, if you could sum up a little bit of this 100,000 survivor database, that'd be really interesting.
Yeah, and again, there are many individuals who have been much more involved than I am in terms of the maintaining that database. It really is, in many parts, a labor of love and very much a testament to the dedication of the Extracorporeal Life Support Organization, or ELSO. But so I would really call out all of those great contributions that are done. What ELSO has done is be able to maintain a registry of participating facilities. I believe you mentioned the survivors. I believe the total run is well over 200,000.
Right.
And encompasses over 600 centers that participate in that registry and in that database. It's essential. As we look at a high impact, potentially life-saving technology that is resource limited and also high risk and fraught with complications, we need data to be able to make sure that we're doing it better. And that's a perfect example of how we can be able to do this and how we can leverage those data sets. I think a big thing that always can be done in the future is be able to continue to broaden that out, continue to have centers participate in this, but also to look at patients who are not on ECMO and to really understand that therapeutic benefit that we're talking about here. Identify that patient who would do well if they went on ECMO, but would do poorly if they did not go on ECMO. That's such the fundamental question with every time we apply this technology. It's something that I think a lot of people have done very well with, but quite frankly, I think we have a long way to go.
Got it. Got it. And then, thinking a long way to go. Again, obviously everything in sort of the biomedical space takes time, but this is clearly an area very ripe for clinical exploration, as you were mentioning. Another very interesting paper that you published recently, this was also in February, in Critical Care Explorations, was about, this strep toxic shock syndrome case. Again, another very interesting, because in this case, not just the lungs and the heart, but the liver and the kidney and really multiple organ failure. Again, the worst of the worst type of cases. What gets you excited in terms of where with obviously there's not unlimited resources, but if there were a nice amount of unlimited resources, where are you taking ECMO in terms of clinical exploration? What are the areas that you'd say, hey, it's never been tried, but would love to go into X, Y, and Z as possibilities for this beyond what we're currently doing now with ECMO?
Yeah, I'd like to first reference what the concept that was outlined in that paper, which I think is probably a very ripe area for clinical exploration, which is this concept of multimodal organ support, which I really do believe is the future of critical care. That much of what we're doing with critical care and that form the basis of why patients were in ICUs 10, 20, 30 years ago, mechanical ventilation, titratable drips, I think will be pushed out towards the long-term acute care range and to the non-ICU beds in the hospital and even to home. And what I really see is I see where the ICU is heading is towards a multimodal form of organ support. And where I think this is a very interesting, for example, in terms of sepsis, is the role of extracorporeal blood purification.
Yep.
With the use of various filtration technologies that are out there that can clear pathogens, that can tamp down on some of the immune dysregulation that exists within sepsis, and even remove damaging things such as endotoxin. I think that there really is a lot there that could be used both in series in conjunction or instead with things like ECMO to really kind of dial in the type of support that's needed.
Those are, extremely interesting areas, and it was intriguing me. You just mentioned in the home, and for those that have, of us that have taken care of a family member in some capacity in the home care environment, are there movements sort of in the? I mean, I know there's different sort of technology suppliers for the many components that go into ECMO, and I've seen pictures of you with it looks extremely complicated, a lot of machines and tubes and so forth. Is there a sort of a movement on the technology side to make things smaller that we could potentially see sort of a home healthcare ECMO type devices in the future?
I think that's where everyone is thinking that again, it's again taking the critical care support to the patient, whether it's at an outlying hospital that needs transport, whether it's in that transport environment, or whether it's being able to disperse the critical care environment across the hospital and beyond. That's what we're all interested in. Yes, there are many efforts that are being made to make ECMO safer, easier to troubleshoot. And I think that's going to contribute to a potential future where you see it in a more broad range of facilities and environments to include maybe home. Look at where ECMO was at 10, 15 years ago only. It was really done at a small number of highly specialized centers by a very small number of providers. And already, I think we're starting to see this. We're seeing a more broad dispersion of ECMO. We're seeing it at centers with lower overall volume, with lower numbers being able to do ECMO, but doing it well. And the more we can leverage technology, I think the better in that regards. I'd love to take a minute to answer your other question about where I think it's heading, because I do have thoughts on that.
Please.
But I really look at where's the shortcomings of how we're supporting our patients. I think we're very good at being able to be able to salvage and support our patients, to support their hemodynamics. Where I think the field really needs to get better is in terms of quantifying what's going on for our patients and being able to facilitate, hopefully, recovery of that organ function in those patients, being able to quantify both the pathogenic response of what's causing the damage, the host immune response of how that dysregulated response might be working against the body, and then finally the effect of the support that we're applying, whether it's conventional methods like the ventilator or the effect of ECMO. And that's been something that we're very involved in doing, and hopefully we'll be able to have some data that we can be able to present very shortly.
Yeah, it's good. It's going to be, again, as you further dive into these applications and these clinical targets, yeah, it's really going to be interesting to see the data that comes out. Again, taking a technology like this, improving it, and then applying it to different indications. Just really, really fascinating work. I'm very excited about it. And again, when I was reading about you, I was unaware that the technology existed at this scale, but to see it unrolled and potentially getting out there for further applications, and it's going to be quite an interesting coming few years. As people who watch the show and listen know, I really enjoy delving into sort of the research history of our guests. And this next question, I'm going to keep us in the ICU, but I'm going to go from sort of the bleeding edge technology back to something a little simpler. But I'd love if you could, while we have you today for a couple of minutes, just talk about. We'll go back to 2015 to the Critical Care Journal, to a paper you published called "Is There a Role for Music in the Intensive Care Unit?" And here you talk about sort of the importance of patient-directed music as an sort of an anxiolytic and sedative option in the critical care patient. Can you say a couple words about this? I just find it personally a totally unrelated to ECMO, sort of, but a really interesting topic on its own.
Yeah, thanks for asking about it. I think it's just it was something I really enjoyed looking into, and something that I really try to remind myself in my clinical practice is just the role of being able to have patient-centered interventions. We don't do it enough. That if a patient is depressed, we tend to say, okay, what kind of pharmacology can we apply? What do we need to fix? We don't think often about the human side of how we're treating these patients. And I think it's just something that we can always do better, especially in the ICU when there's so much depersonalization. So it's something that I love to continue to see in my clinical practice. I love when we have patients who have pictures of their family members and of themselves doing various things around their ICU. I love when there is message boards and encouragement. I love that being able to personalize things like the favorite music for patients, and being able to assess what they can do. And again, it's something that I think we can really leverage technology for a patient who is hypoxic, who used to be deeply sedated and deeply paralyzed and just have their lungs being subjected to high mechanical ventilation settings. Now with things like ECMO, we can have them off the ventilator. We can have them walking around. We can have them being able to go outside and interact with family. During COVID, we had 2 people who got married on support in a very touching ceremony. And we not only is it touching and it's heartwarming and it reminds us of the human side of what we do, but quite frankly, it works. That every time I've seen a patient start to take steps and really participate in their own recovery, I know that physiologically their recovery is right around the corner, and it's something that I think we should leverage a little bit better as we go forward.
Outstanding. Outstanding. Jeff, what's coming up for the rest of 2024? I see that, you aside from obviously taking care of these patients, you get out there sort of on both the scientific and the business conference circuits. I think you were at the annual Shock conference a couple weeks ago, and then something coming up called the Texas Cardiovascular Innovations Conference in August. What else is happening that we should know about while we have you today? Places that we can listen to you give a lecture or run into you, meet you. Anything else that I missed while we have you today, please?
No, I appreciate the opportunity. Yes, we'll be running our ECMO session at the Texas Cardiovascular Innovations Conference, really trying to focus on that intersection between patient care and innovation. And then the discussion will be very technology focused. I'll continue to present the research that we have coming out. What I'm hoping to do in the next year is really present a lot more of the molecular data that we're collecting with our biospecimen repository, and hopefully start to answer some of these questions of what is the quantified effect of ECMO, what is the quantified difference for patients who are recovering versus not recovering. And my hope is to be able to really start conversations around what can we do better to facilitate patients recovering faster, better, and with a higher quality of life. So much more to come, and I'm very excited to hopefully really present a lot of the things that we're working on. There's much more to come. I'm very excited about it.
I'm excited for you. I look forward to doing a follow-up with you down the line, but really, really great work, Jeff. And just, so appreciate the time that you took to outline it all for us, and wishing you and your team the best with it all. For everybody that's going to be listening to this particular episode across the various podcast networks or watching on the YouTube channel, again, you've been listening to Dr. Jeffrey DellaVolpe, medical director of the adult ECMO program at Methodist Hospital, also medical director of their cardiovascular intensive care unit, as well as the Texas IPS critical care service line. And you can pick up a copy of his book, major booksellers, the ECMO book, which came out in 2023. Jeff, again, I want to thank you for taking the time out of your schedule to talk to us, to educate us on this topic. Obviously, thank you for all you do to save lives. And as we like to say on our show, thanks for helping to create a better tomorrow for millions of patients out there. Really a great story, and I look forward to continue to follow you and hopefully do a follow-up next year with you.
That'd be great. Thank you, Ira.
Great having you.